Okay, so I'm talking about paraspinal blocks. Now, there has been lots of talk on paraspinals already, so I won't go into too much detail about erector spinae. I will, however, mention some of the other blocks. But first off, paraspinal blocks, there's the paravertebral block versus the fascial plane blocks that have been discussed. I will be discussing some other ones that have not yet been discussed. But first, before we get there, I would like to go back to the basics of fascial planes and just make some, just challenge your ideas about the fascial planes again, and then bring home some important concepts on this and what the evidence says on the blocks. So first, fascial planes, there is a new one every month almost, it feels like, because, you know, this is just a list of some of the fascial plane blocks. You know, they're getting more and more because they're easy to do. Now, first, fascial plane blocks, they are all amenable to ERAS principles. Your patients can mobilize early. There's no big side effects. You don't have to stop any anticoagulation. And they can mobilize and get home as quickly as possible. They are safe to do mostly because they are low risk type of blocks to do. They are efficient time-wise because you don't specifically need to find a nerve. Even in large patients or where you have some disturbed anatomy, you just have to find the fascial plane. Are they effective, however? Now, yes and no. What we found is that all fascial planes are equal, but some are more equal than others, if I can quote George Orwell. So the problem with fascial plane blocks is that they have poorly defined neuronal endpoints. Now, not all of them, this doesn't apply to all of them, but usually we say that we are aiming for these nerves, but is that exactly what causes the pain relief? There's no specific exact targets unless you have a specific nerve in that plane that you are blocking. Then what is the value of fascial plane blocks in opiate-sparing analgesia? And as Madan, mentioned, that if you do a spinal with an opioid, then doing tap blocks has no specific extra use. So if we're doing fascial plane blocks, they should add value to our patient and avoid opiates. So, or decrease the amount of opioids needed. So there should be positive effects and not just we're doing them because we like doing regional anesthesia. Now, this is a fantastic article. I would invite every one of you to go read. It is open source. Please have a look at it. It explains everything in detail. I will go through some of the concepts here because I found this mind-blowing just to put fascial planes back in the forefront. So firstly, what we're talking about fascial planes is there is a superficial fascia and then there's a deep fascia. And the deep fascia is what we're interested in. Superficial fascia doesn't really matter to us. So deep fascia between the muscle and the deep adipose tissue. So these fascia layers are everywhere in the body and they have either 1, 2, or 3 layers, depending on where. So they are collagen containing, they are discrete from the muscle. So we have fascial layers on the muscle and the, the muscle fascia themselves, but we have discrete deep fascia layers as well. And they form sheaths for our neurovascular bundles. All the neurovascular bundles move in that area. And then there is a potential space then for our regional anesthesia or local anesthesia to move in, which makes it much easier. Now, when we think about fascial plane blocks, there's a difference between doing a femoral nerve block or a fascia iliaca block. a femoral nerve, you can use a very small amount to target the nerve specifically and get your effect. All the fascial plane blocks, you need some more volume to reach your target. But it is both end up in the same kind of effect, pain relief. Now, once you think about fascia, it's not just a piece in between muscles. So I would like to just tell you a little bit more about the biomechanical functions of fascial layers and how that impacts what we do. So firstly, muscle tendons insert onto the fascial planes. And because of this, these muscles, as they contract, they pull on the fascial planes, causing motion. Then fascial planes also have their own contractile elements. It's not that it's just a rigid structure. They contract in and of themselves to get fluid to move away from or into that area. Then fascial planes also act like an energy absorber. Now, the biggest ones that you can mention here is the thoracolumbar fascia, where the motion and posterior anterior motion helps. And with your Achilles tendon, those fascial layers absorb energy and act as a potential for energy release when it's needed. So I would like to challenge you to not think about fascial layers as a double-click solid thing that you have to push through to get it into the right position, but think of it in a dynamic fashion where fascial planes aid your regional anesthesia rather than it's just a place to put it. So fascial plane innervation, when you think of fascia, they themselves are innervated. It's not just a structure with no feeling. There are both alpha A and C fibers on them, and these fibers are of a wide dynamic range. So these neurons not only measure stretch, they measure a whole spectrum of things. And when you go into chronic pain and chronic stretching, then the mechanoreceptors and adrenergic receptors change function and can actually aid in pain transmission. So fascia can hurt. Then all of these help to contribute to the mechanisms of your plane blocks. Now, we don't know to what extent blocking the fascia, because you're putting in local anesthesia in a fascia, and the fascia isn't just a solid structure. It is a structure with innervation, with muscle contractures. So blocking a fascia has more effect than just a space to put local so that nerves pass there. Now, when we're thinking about the layers, depending on where you are, some of them are more mobile and less mobile. So when you look at the pectoral region, the pectoral fascial layers, there's two of them, have much more mobility than, for instance, the thoracolumbar fascia. And the more mobility you have, the further your regional anesthesia can be pushed by muscle motion. Also, the anatomic position of where the fascia is and where they are in relation to organs also depend on how far your regional can spread. We looked at continuity of spaces, and I'll go into a bit more detail about that just now. So if you have a fascial plane and you do regional anesthesia in that plane, how does it work? How do we get there? Well, firstly, it's a transmission belt. The way we've been thinking about this, you put regional anesthesia in a plane and the nerve passes through that plane, and well done, you've blocked the nerve. Or you inject here, the regional anesthesia flows in that plane and blocks the nerve over there. It's safe, you're not close to the neurovascular structures. It's fantastic. The other one is by proxy. You put it in the one plane and it moves into another plane. Now, what do I mean by the transition or transmission belts? We have a continuity of the fascial system. So if you look at the fascia in just for instance in this plane, so where you would do the erector spinae block, here is our retrolaminar area. So the fascia in this entire layer is continual. It continues also further anterior so that your serratus anterior area, both of these are just different areas where you can block serratus anterior. So that is a one continual space. So theoretically, if you gave enough volume, you would be able to spread this volume. But depending on the way the muscles work and contract, and that will push your regional in a specific area. So remember that once you put regional in a specific area, it's not just there. It works further than you have just thought about it. And the effects are more pronounced. And we see that in practice as well. So when you do a block, you put regional in a specific area, but the effect is far greater than you would have expected. And especially if you use larger volumes, not necessarily a higher concentration, but the volume is a big important thing. Then just to show you all the blocks. Now, this is a whole list of them. I will go into detail of some of them, but they're all targeting the same fascial plane. So if you go the retrolaminar block, your erector spinae block, your midpoint between the transverse process block, your paravertebral block, your RIS or rhomboid intercostal subserratus plane block, your serratus anterior plane blocks, whether below or above. You know, all of these target the same fascial plane. And thus, theoretically, there's the same block. But there are some differences, and these differences are important. So, by proxy, this is how we see our erector spinae. You put local anesthesia over the transverse process, and we get spread through fenestrations in the fascia, and it moves deeper and blocks the roots of our nerves. That's why we get not only the somatic pain relief, we can also get some visceral pain relief as well, because it spreads towards our sympathetic chain as well. Now, let's look at some of these paraspinal blocks. Firstly, the paravertebral block. I'm not going to go into too much detail. My colleagues have done a fantastic job on this, so I won't waste your time by going through all of them again. It works well. This is the block with the most robust information about it. It's been used since long before, you know, it's first time in the 1950s it was described, then the 70s again, and then late 90s it really took off again as a block. This is one that I did. So we see our transverse process. I always do it in the transverse in plane, you know, way. I never put in a catheter. I have found that catheters with the paravertebrals, they just cause problems. And I haven't had good success, you know, 50%, 60% work well. That's not acceptable for me. I rather do a block that works perfectly every time or close to every time. So single shot, yes, works really well. You have your transverse process, and then as you go through, this is our lung with pleura. We see our paravertebral space here and our costotransverse ligament. Once you pop through there, you do feel a noticeable click or a change in resistance. And then as you insert it, we see your pleura being pushed away. Won't go into further detail. Then paravertebral by proxy. Now that's our retrolaminar blocks and our midpoint the transverse process. So looking at these blocks, here is our retrolaminar. Now this is in a parasagittal. So what we would find is you look at the spine and then you go parasagittal just off the midline, and then you would find your lamina. You would also go under your erector spinae muscle and inject between the bone and the erector spinae in the parasagittal plane. And there you see your spread over the lamina. Now, this, when you're looking at the study, this compared to your erector spinae, the spread to superior and inferior nerve roots are less. It's at least 1 to 2 spaces less with a retrolaminar block than you would have with an erector spinae plane block. So this block works, but it doesn't work as well. You don't get as much spread, and you have little to no spread to your for visceral pain coverage. So retrolaminar looked great to start off with, but not so easy to do and not so effective at all. Then midpoint to the thoracic. So this was aimed at not popping through your ligament, just injecting right above the ligament, but halfway between your pleura and the lower, your erector spinae fascia. So you inject in the muscular layer there. And what they found was that this block is obviously less dangerous than your paravertebral block. It is easy to perform, and you just have to be somewhere in that region. It is non-inferior to your erector spinae or to your paravertebral. They have similar pain effects. This is faster to do and easier to do because you are just aiming for something halfway in between there. You don't have to feel a click. You don't have to open up a fascial plane. Problem here is with spread. You cannot get enough spread to cover a wide area. So if you have a very small area, about 4 dermatomes, 3 to 4 dermatomes, this is a very easy one to do. Single shot, do it. It works quite well. You need very little expertise to do this one well. But to put in a catheter, long-term pain relief, this is not the one to choose. Then your serratus, the serratus plane block with, sorry, don't know what happened there. Okay, so once we're looking at your subserratus block, now this block hasn't been studied that well. It is easy to do. It's exactly the same as you would with a subserratus block. It's in exactly the same plane. You just do it more posteriorly. So theoretically, the effects would be exactly the same as with your serratus anterior plane block. Now, there is still lacking research on this. It has been, described in cadaveric studies, but it's not really used in practice. There are more useful blocks to do. This, however, is an easy one to place a catheter. So if you wanted to place a catheter and you couldn't get close to the area of subserratus, if they were working in the axilla itself, this would be a better place to put it. Okay, then once we look at the evidence, paravertebral, I didn't go into detail, but paravertebrals, we know the acute pain scores go down, chronic pain decreases. You have decreased in relative risk in chronic pain in loads of trials. Rescue analgesia nearly halves your requests for rescue analgesia, and post-operative nausea and vomiting is 5 times less than with just a general anesthesia if you add a paravertebral for pain control. Now, erector spinae, won't go to all the research there, but again, you have decreased VAS scores, reduced opioid requirements, and that's compared to systemic analgesia alone. Then all of these other newer blocks have shown spread on cadaveric studies, whether better or worse spread. Case reports, we have the experts doing them and they get fairly good results and some promising case series, but there is no large randomized control study. We have no big data on them. People aren't doing them as often, just because we have well-working, easy-to-do blocks in our ESPs and serratus planes, and these kind of blocks, they work well and are amenable to catheter techniques that can extend their length for days. I recently had a patient with rib fractures who I put in erector spinae for, and we kept it in for 2 weeks. And her respiratory functions were fantastic. She initially came in with, loads of trauma. Her lungs were not in a good state. And with rehabilitation and good pain management, 2 weeks later, she was into the normal ward. Catheters were out, and she could go home after that. Okay, then just in summary, a fascial plane isn't a closed space, so it's not just the one area where you inject. It moves, and it moves more or less depending on the fascial planes, whether they're more dynamic. Do not think of it as a thing that you pop through to put in local. It is a dynamic structure that moves and has a function. Fascial planes are not all equal, and they're not all equally effective. Though the retrolaminar space and your space for erector spinae is exactly the same fascial layer, the effectiveness is decreased with your retrolaminal. So not all fascial planes are created equal. Then cadaveric studies do not reflect real life. So if you inject into a cadaver and it shows this spread, you will not see that spread in a breathing human where you have motion of the fascia, where you have live fascia. So you will either have a more prominent one or a different spread to then what you would see in cadaveric studies. Then what is the clinical significance of these blocks? Are they important? Is it important to do a retrolaminar block for certain indications? And what would those indications be? Would you rather do a midpoint transverse process block? When? And what would those indications be? So once you think about fascial planes in this area, in this way, then you start seeing, look, some of these blocks seem useful, but are they? I'm not saying that they're not. I'm just saying that think about what you're doing before you do it. It's not just injecting something, it's injecting something with a specific aim to decrease opiate requirements, to increase better pain control, to help your patients get out of hospital and get back to their families and enjoy their lives further, because it is short. So on that way, thank you very much for your attention. Please come and visit me in South Africa. I am in the Garden Route area. I will show you just some of the pictures from close to where I live. Please come, climb a mountain. The mountain is just outside my window now. This is the city that I stay in, George. This is the mountains from the top and the beach close by. So please come. We don't have as much COVID as you think, and it's free to travel. And it's currently summer with 31 degrees Celsius.
For such fantastic presentations and for such fantastic pictures in the end. And we hope the next time we will see each other in Kyiv, in Lviv.